Today I would like to speak to you about palliative and hospice care. My name is Barry Miskin. I'm a board-certified general surgeon at Jupiter Medical Center. I'm also a board-certified hospice doctor for Trustbridge. I'm board-certified in hospice and palliative care, and it's my pleasure to talk to you today about this topic of palliative and hospice care. We're going to cover descriptions of palliative care and hospice. We'll also go into when to use palliative care, when to use hospice care, what they are, and we'll start with a brief history of both. I think it's important to know where we came from with hospice and palliative care so that we can figure out better the direction that we are going. Best to go back thousands of years to 8000 BC during the Archaic period. This is the first recorded evidence of hospice care. A man named Guy Skiles in 1937 found a mummy in a rock shelter near the junction of the Rio Grande and Pecos River in South Texas. It was kept in a private small museum in 1968. It was then loaned to the Institute of Texan Culture. Scientific work was done on the mummy in 1970, 80, and 86, but nothing really happened until the technology advanced and we had electron microscopy in 2003. The Skiles mummy was one of 3 mummies found within this area. This dates back to 1,000 to 1,400 years ago. They were naturally mummified. Carl Reinert, a researcher from Nebraska, took things a step further and took a look into the mummies internally and noted that they all had megacolons. The Skiles mummy had 2.6 pounds of feces that was preserved within the mummy. He took the research a step further. The colons in all 3 mummies were distended 6 times normal, consistent with Chagas disease. It was noted that the type of food that they had within the intestinal tract was grasshoppers and flowers and things that were not normally part of their diet. This was significant because it was believed that the people within their dwelling went out and foraged for food for them and fed them these things to try to save them or to make their last few days on earth comfortable. The grasshoppers, interestingly enough, had the legs pulled off. This was the first reported evidence of hospice care. Next, we fast forward to Greek times. This is a ruin from an ancient Greek temple of healing called Ascapia. There was over 300 of these in ancient Greece, and they were usually located in secluded areas surrounding modern spas or mountain sanatoriums, and it was about the 8th century or 500 BC. This is a statue of Asclepius. He was the Greek god of healing, and every night for 1,000 years, from 500 BC to 500 AD, the sick and afflicted pilgrims would go to these temples of Asclepius. Healing and advice was sought, but this is where people went to die. The Roman Empire followed by creating a hospital system as well. And their hospital system was more for repairing their wounded soldiers. The mutilated and the dying were far down on their priority list. After the First Crusade in 1113, hospitals were set up. They had room for 1,000 to 2,000 people with 150 staff. They cared mostly for poor people who were sick and for wounded crusaders. It provided the ideal of what hospitals should be for many centuries. In the hospitals, the poor, the wounded, and the sick were considered lords, and those who looked after them their servants. Hospitals were mainly for providing hospitality, which the word hospice came from later. They were often called maison Dieu, or in English, God's house. The hospitals were a house because it was always part of a religious community and a household with God at the head of it. There's many remains that can be found throughout Europe and throughout the world. After the First Crusades, it was necessary to keep the lands that they had conquered. The Hospitaller Knights were given this duty. They were originally monks, and they were trained not only in defense and battle, but they were also trained in care. They set up a group of hospitals along the route to Jerusalem to take care of the pilgrims that were going there. A lot of the pilgrims were sick and dying, and there was little distinction for taking care of a sick person versus a dying person, and many people died in these hospices or these lodging houses that they started. Hospitals are something that you probably wouldn't associate with the 14th century, but interestingly enough, most medieval towns had one or two hospitals, and they were staffed by nuns or monks, and usually people shared a bed, they had a fire, and they were set up for comfort care for the sick and the dying. Most of these places provided care to the poor, and they were set up with funding from charities, and they took many forms, and they were known as hospices. This is an example of a surviving medieval hospital. This type of hospital had a different type of function than hospitals today. This is a place where people went to die with comfort. It was extremely busy, especially during the middle of the 14th century with the Black Death. This is the inside of a preserved French hospice from 1443. This was the room of the poor. The room was furnished with 2 rows of curtained beds, and the center was set up with benches and tables for meals. Each bed could accommodate 2 people. They had large wards, and they were located near chapels, so the bedridden could attend Mass from their beds. This is a Hotel Dieu. It was set up in 1443 and continued to care for the poor and dying up until 1971. It was in the Burgundy region of France. It was set up with an office, an apothecary, and a hospital. And the sick were housed near the chapel. The nuns took care of them in the center of the complex. The elderly, the disabled, and the sick found comfort here for many years. This is Mary Aikenhead. She was born in Cork, Ireland in 1787. At age 25, she became Sister Mary Augustine and was established almost immediately as superior of a new order known as the Irish Sisters of Charity. This was the first of its kind in Ireland that were uncloistered. The sisters decided to open a hospital. She sent 3 of the nuns to Paris to Notre Dame to study. When they returned, they opened up St. Vincent's Hospital in Dublin in 1834. Mary Aikenhead succumbed to a chronic illness, and the convent where she was living in her final years opened up Our Lady Hospice for the Dying in 1879. This and other services provided by the order ministered to the needs of the highly impoverished population within Dublin, where mortality was very high. Our Lady's Hospice subsequently opened its doors with 27 beds, and then eventually it spread and opened Sister of Charity hospices in Australia in 1890, England in 1905, and Scotland in 1948. Unfortunately, during the 1850s, many poor people died at home or in the streets. This is a famous painting, The Poor Man's Death, in 1850 by the French artist Jean-Pierre Alexandre Antigna. He lived among the poor and painted many pictures about their lifestyle, and this was more the rule than the exception before formal hospice programs were in place. Frances Davidson founded the first home for the dying in Britain. In 1885, she was born in Aberdeenshire, Scotland. In 1840, she grew up in a middle-class home in a family of faith with an ethic of service. In 1870, she went to London and started visiting the sick as part of the work program at Mild May Mission. The mission was started in 1866 with the outbreak of cholera. The mission eventually started a medical mission hospital in 1877. The hospital was recognized for the training of nurses in 1883. It appears that Francis Davidson, building on her association with the mission, inspired by the needs of those dying from tuberculosis in particular, developed a new idea to create a home of peace for the dying, and for reasons which are still not clear, she adopted the name Friedenheim to describe it. She located the first one right near the mission headquarters. She devoted her energy to its causes right up until her death in 1920 at the age of 80. Preference was given to whom had mortal illness and who had reduced their circumstances, that their only options were the workhouse infirmary for the dreaded last resort. Initially, Friedenheim had 8 beds, but in 1892, a move to new premises gave accommodations for up to 35 patients. Admission was free, and there were some private rooms for those who could afford to pay. In 1950, Teresa founded the Missionaries of Charity, a Roman Catholic religious congregation that had over 4,500 nuns and was active in 133 countries in 2012. The congregation manages homes for people who are dying of HIV, leprosy, and tuberculosis. It also runs soup kitchens, dispensaries, mobile clinics, children's and family counseling programs, as well as orphanages and schools. The members take a vow of charity, poverty, and obedience, also profess a fourth vow to give wholehearted, free service to the poorest of the poor. Teresa received a number of honors, including 1979 the Nobel Peace Prize for her work with the poor and the dying. Mother Teresa was born Agnes Ganja Bayaju, Albanian. Teresa left home in 1928 at the age of 18 to join the Sisters of Loreto to learn English. She knew that English was the instruction language of the Sisters of Loreto in India and the missionary work that they did. She arrived in India in 1929 as a novice nun in the lower Himalayas, and she learned Bengali. She took her solemn vows May 14, 1937, and was a teacher at the convent school in eastern Calcutta. Her time there, she was extremely disturbed by the misery, death, and poverty in the city. On September 10th, 1946, she was on a annual retreat, and she wrote this in her diary. Quote, "I was to leave the convent and help the poor while living among them. It was in order. To fail would have been to break the faith," unquote. So no one knew it at the time, but Sister Teresa had just become Mother Teresa. She asked for and received permission to leave the school in 1950 and founded the Missionaries of Charity. She went out to serve humanity with 2 saris with blue borders. The Vatican granted her permission to start the Missionaries of Charity. In her words, it would care for the hungry, naked, homeless, crippled, blind, and lepers, all those people who feel unwanted, unloved, uncared for throughout society. Her first year was fraught with difficulty. She had no money, and she had to beg for food. She kept wanting to return to the comfort of the convent, but she persisted. The officials in Calcutta noticed what she was doing, and they helped her open her first hospice in 1952. She converted a Hindu temple into what was known as the Home of the Pure Heart. All the poor and dying that were brought there were allowed to die with dignity in accordance with their own faith. Muslims were read the Koran, Hindus received water from the Ganges, and Catholics were given last rites, a beautiful death. Teresa said, quote, "This is for people who live like animals to die like angels, loved and wanted," unquote. All these events and people brought us to modern day hospice care as we know it. This is a rare photo of 2 of the most influential people in the 20th century for hospice care. Dr. Kubler-Ross, who wrote Death and Dying, she's the person to your right, and Dr. Cicely Saunders, who is the founder of the modern hospice and palliative care movement. She introduced the term total pain. For 3 decades, Dr. Saunders disseminated her beliefs through worldwide speaking tours and her best-selling book titled On Death and Dying. Her work changed how we view hospice and end-of-life care in modern medicine. She's often single-handedly credited with ushering in the modern hospice movement. Dr. Saunders was the first to observe that her patients' pain included not only physical but also emotional and mental suffering, and also suffering from their social problems and their spiritual need for security and meaning. Accordingly, she coined this concept, quote, total pain, unquote, and provided a framework for assessment of patients in palliative care. She initially started studying politics, philosophy, and economics at St. Anne's College in Oxford in 1938. During the war, she decided to become a nurse and trained at Nightingale School of Nursing, based at St. Thomas Hospital from 1940 to 1944. She then returned to St. Anne's College after a back injury in 1944. She took a bachelor's degree in 1945, qualifying as a medical social worker in 1947, and eventually she trained as a doctor. In 1948, Dr. Saunders fell in love with this patient, David Tasma. He was a Polish-Jewish refugee who survived the Warsaw Ghetto. He worked as a waiter and was dying of cancer. She visited him daily on her rounds and became very close to him. When he died, he left her everything he had, which was $25,000. The donation that he gave her, he asked her to use it as a, quote, a window in your home, unquote. And she did. And she started St. Christopher's Hospice in London and memorialized him with a plain sheet of glass in the hospice entrance. Dr. Saunders set up St. Christopher's Hospice in 1967. It was set up for teaching, research, and expert pain and symptom relief. It addressed social, psychological, and spiritual needs of the families and patient. It was the first type of hospice at this time where it was set up on a different model, like a home away from home, where patients could participate in gardening or have their hair done or write or talk. She became the medical director from 1967 and then in 1985 as its chairperson, which she occupied until 2000 when she became president. This changed hospice care. Elizabeth Kubler was born on July 8, 1926 in Zurich, Switzerland. She was one of a set of triplets, 2 of whom were identical twins. She was 2 pounds when she was born and barely survived except for her mother's devotion. At age 5, she ended up getting pneumonia and was hospitalized and had her first experience with death when her hospital roommate died. Because of this experience, it led her to believe that death is a necessary stage of life and that we need to prepare for it, to have a death with dignity and peace. During World War II, Elizabeth worked as a laboratory assistant for refugees in Zurich, and at only 13 years of age, she did relief work in France, Germany, Belgium, Denmark, Sweden, Czechoslovakia, and Poland. From a young age, she was determined to become a doctor, despite her father's efforts to force her to become a secretary for business. She refused him and left home at age 16. She worked to support herself in a variety of jobs, gaining major experience in hospitals while volunteering to provide aid to refugees. In 1954, she visited Maldenek extermination camp in Poland. This started her interest in the power of compassion and resilience to the human spirit. The horror stories of the survivors left permanent impressions on her. Also, she was affected by the images of hundreds of butterflies carved into the walls there. To Kubler-Ross, the butterflies were the final works of art of those facing death. This stayed with her for years and influenced her thinking about the end of life. During the same year, she also became involved with the International Volunteer Service of Peace as an activist. Dr. Ross graduated from medical school at the University of Zurich in 1957 and moved to New York in 1958. She began a psychiatric residency program at Manhattan State Hospital, which is pictured here, in the early 60s, and she basically focused on schizophrenic patients and on also hopeless patients, which was a term used at the time for terminal patients. Treatment programs were poor, and there was no sense of dignity or self-respect for these patients, and Dr. Ross intended to change all this. She was horrified with the neglect and abuse of the mental patients, as well as people that were imminently dying. In 1962, she accepted a position in the University of Colorado School of Medicine as a junior faculty member. Dr. Ross had her first interview with a young terminally ill woman in front of her class of medical students. Her intention was not to show somebody an example of pathology, but she wanted to depict a human being who wanted to be understood and who was dying and who was coping with the illness and how it was impacting her life. She stated to her students, "Now you're reacting like humans instead of scientists. Now maybe you'll know how a dying patient feels, but you'll also be able to treat them with compassion, the same compassion that you would want for yourself." Dr. Kubler-Ross accepted a position as instructor at the University of Chicago, which is pictured here in 1965. She questioned traditional psychiatry, and she started to conduct regular weekly educational seminars, which consisted of interviewing terminally ill patients in front of her students. She had a large amount of resistance from the medical staff, but in 1969, Life magazine caught wind of what she was doing and wrote an article on her. This brought public awareness to her work with the terminally ill and changed her whole career. Because of the intense scrutiny her work received, it had an impact on her career path, and she stopped teaching and she started working privately on what she called the greatest mystery in science, death. In 1969, she published On Death and Dying, a groundbreaking book. In the book, she had over 500 interviews with dying patients, and she argued that terminally ill patients had a right to decide about their end-of-life care, whether they wanted to be home or in an institution, and they had a right to die with dignity. In her famous book On Death and Dying in 1969, she also proposed the famous 5 stages of grief. It's basically somebody's reaction when you're faced with imminent death or bad news. It's the 5 stages of grief are pictured here. After 2000, an increasing number of companies, interestingly enough, began using the 5-stage model to explain reactions to changes in the loss. We're going to go into more detail in palliative care. Palliative care grew out of the hospice movement. This is Dr. Balfour Mount. In 1974, he was a urologist. He was familiar with Dr. Saunders and Dr. Ross's work. He coined the term palliative care. The term hospice was problematic in bilingual Canada. He introduced the term palliative care in the mid-70s. The term not only eased the acceptance of hospice services in Canada, but it also gained widespread usage throughout the world. This is an aerial view of the Royal Victorian Hospital in Montreal. This is where the first palliative care ward was opened up. Since that time, there's been many advances in hospital-based palliative care programs. In 1987, Cleveland Clinic established the first palliative medicine service in the United States and Ohio. It later expanded into the first palliative care clinical and research fellowship training program. The Connecticut Hospice was founded by 2 pediatricians and a chaplain. It was the first hospice in the United States. It started in 1974. In 1986, the Medicare hospice benefit was enacted and states were given the option to include it in their Medicaid programs. For the next 3 decades, legislation was passed for funding and improving Medicare reimbursement for these programs. There's now over 4,000 hospices in the United States. This is a picture of the Connecticut Hospice today. They took over a tennis club and they're right on the water. They transitioned into the site of the Double Beach Club. Again, this is the Connecticut Hospice today, and they have 52 beds in this waterfront inpatient facility, and I think this is what hospice should look like, spending time, your final hours with your family in a beautiful environment. One of the first hospice inpatient units in the country was at Yale. Jupiter Medical Center has an inpatient hospice unit now too. It has a separate entrance. Here's a picture of the unit. Rooms are designed for the patient and family's comfort. Let's go into a little bit more detail about palliative or hospice care. The first thing to consider when you're evaluating your patient is who is appropriate for palliative care or for hospice care, and how can we help? There's a continuum of care which starts with acute care, palliative care, and finally ends with hospice care. We have a number of patients that have chronic illness with refractory symptoms that are burdensome to them, and they constantly utilize the services of the emergency room, where if they're referred to palliative care service, they could avoid the constant return trips to the emergency room in the hospital and be better managed for symptoms like breathlessness, constipation, diarrhea, anorexia, insomnia, pain, anxiety, depression. Palliative care takes into account the many traditional methods of clinical assessment and the holes in those services where they're not looking at the whole person, the anxiety, the depression, the family, the interpersonal interactions, and things that are not what we traditionally evaluate. Patients that have chronic disease or malignancy and they have a prognosis of more than 6 months to live would benefit greatly from a palliative care evaluation and service. Palliative care is a conversation with the patient and the patient's family and also all the medical and social caregivers so that everything can be coordinated and the patient can deal better with their chronic disease or malignancy. These are the variety of services that are provided by these palliative care programs. The highest identified services are really goals of care discussion, family and patient education, symptom management, comprehensive assessment, and also advanced care planning. I think the take-home message here is that palliative care looks at the individual as a person, not just a disease entity. Somebody that has a spiritual, physical, and family situation helps them deal with it better in the context of their disease state. This shows where the majority of palliative care services are provided. This is where the money comes from to help fund palliative care. There's a shift from curative treatment to symptom management when, cure is no longer possible, and it's putting the patient's goals of care, wishes, and dignity and comfort first. This diagram again illustrates continuum of care. At a certain point with palliative care, the disease state becomes so severe the person has less than 6 months left to live, and that's when hospice care would be appropriate and would take over. This is a good example of a patient that might be appropriate for hospice or palliative care. This slide gives examples of disease milestones where a patient may be appropriate for hospice. If you can't get them off a ventilator, they're dependent on all ADLs, or they don't want to have dialysis, or some of these other examples given. This shows some helpful assessment tools that you can use to determine somebody's eligibility. These are real turning points in patients' treatment for the patient and the family, where they have to make some decisions in the direction that they want to go. Feeding tube placement is a big decision for the patient and the families, especially if the patient doesn't have a living will and wasn't able to express their wishes before. Intubation is another one of those milestones. A lot of times people have severe end-stage pulmonary disease and they're never coming off a ventilator. And if you can't come off the ventilator, do you want to have a tracheostomy forever? Or if you have ALS, is that your next step so that you can continue surviving? These are all major decisions and major crossroads in different illnesses. We see a lot of people in hospice that have been on dialysis for years and years, and finally they don't want to continue, or the next step in the treatment of their illness is to start dialysis, and a lot of people don't want to do that either. So these are the type of people that would have definitely less than 6 months or less with renal failure to come into a hospice program. For years, the medical profession has largely fumbled with the question of what should we do when there's nothing more that we can do. So this is your last year of life, and this hasn't changed for the last 30 years. 80% want to avoid hospitalization, but they still go to the hospital. Medicare spending in the last year of life is 6 times what it is for other patients, and this accounts for 25% of the Medicare budget. In the last 6 months of life, the average patient makes 29 visits to their doctor's office. The last month alone, 50% of Medicare patients go to the emergency room, 33% are admitted to the ICU, and 20% will have surgery. So I think this best describes hospice care, and I think the main point here is hospice care is palliative care with somebody that has 6 months or less to live. I think here's some more interesting statistics about hospice. 28% enroll in the last week of life and 10% in the last day of life. This is a breakdown of hospice diagnosis as of 2018, and you can see that non-cancer diagnoses are far more common than cancer. And this is the location of hospice deaths, and the majority of people want to die at home in their own bed. This is the hospice interdisciplinary team and the hospice care model, and it can include registered hospice nurse, a hospice physician, the primary attending physician, a social worker, a chaplain, home health aides, bereavement counselors, and community volunteers. This is what people want at the end of life: truth, time, and touch. 88% want the doctors to be completely honest, yet 88% of the patients want to be told the truth, and most will want a second opinion. Most people want the right to be in control. Dying with Dignity Act is a nonprofit organization of volunteers committed to have reform that will enable ACT citizens to have end-of-life assistance so they can have a peaceful death. This is an Australian organization, and that's basically what most people want. They want to have a peaceful death. There are many myths and truths in this world, and the same is true with hospice. Most of us think a whale can swallow a car or a person, but the truth is a grapefruit's the biggest thing a whale can swallow. This is a common misconception and misperception about hospice, that once hospice comes in, the patient will be given the big shot that will end his life, and that will be it. And a lot of times we have patients and families calling us and saying, we're ready for the big shot. Well, there is no big shot. Hospice is here to help people live better and more comfortably, and to help them spend their last few days without pain, without fear, and maybe even live longer because they are more comfortable. This is another myth. People can easily drown in quicksand. Well, the truth is, quicksand is dense, so no human or animal can drown in it. So all those Tarzan and jungle movies and westerns and all where people are drowning in quicksand are not really true. They're just myths. One of the common myths that we see with hospice care is once you sign up for hospice, you have 24/7 care around the clock in your house, or you can go to a hospice facility. And this is not true, but what is true is if you have uncontrolled symptoms or you're imminent at the end of life, a nurse can be placed in the house around the clock to take care of you, or you can go inpatient to a hospice facility to care for you so that you pass in comfort. I always thought Van Gogh cut his whole ear off, but it's not true. He only cut off the tip of his earlobe. When your patient signs up for hospice, or you sign up for hospice, you can keep your own doctor. You don't have to have the hospice doctor, or you can have the hospice doctor and your own doctor take care of you. Most people believe that you have to get rid of your doctors once you sign up for hospice, and this is not true. Hospice can not only provide care and medical support and services to the patient, but also to the family of the terminally ill and to their caregivers as well, to achieve comfort and quality of life until death for the patient and comfort for the families. And this is all done with an interdisciplinary team that addresses physical, psychosocial, and spiritual aspects of suffering. Here's a list of some hospice services that are provided. Respite care is very big, especially for caregiver breakdown, which we see a lot. And the crisis care is what I was talking about at end of life, or for symptom management and inpatient care centers. Who pays for hospice care? Medicare, Medicaid, private insurance, and donations. Our mission in hospice is to make sure that people do not have any pain and do not have any fear at the end of life, and they have a comfortable death. We covered the early history of hospice and palliative care, and also the differences and similarities between palliative and hospice care and when we would utilize them for our patients. Questions? Here's a list of references. Please contact me if you wish a full list of references.